thank you for invitation, and I would like to start our presentation and to tell you something about our experience. First of all, we would like to say that we don't have any potential conflicts of interest to this report. And we will start with a brief introduction, then to move to the microsampling strategies and their application. After that, we share our own clinical experience, and finally wrap up with questions and discussion if you will have any additional things to ask. I would like to start by reminding you that the standard method to therapeutic drug monitoring is venous blood sampling. It was established method by widely used around the world, but not without its limitations. Each sample required severe milliliters of blood, usually between 1.5, 2 or 5, depends on the size of the tubes. In transplant patients, especially in the first day and weeks after surgery, frequent sampling is needed. And sometimes it's mean daily sampling or even multiply-day samples. In children, the problem becomes particularly serious because their total blood volume is much smaller than in adults, and the limits of World Health Organization, as you see, are often exceeded in the practice. This carries the risk of the iatrogenic anemia, increases the patient's discomfort, or creates an additional burden for both staff and hospital logistics. As an alternative to conventional blood draw is microsampling, and according to HCH definition, a microsample is any blood sample less than 50 microliters. In practice, it means that instead of milliliters of blood, we will take only 2 or 3 drops. Such samples are most often collected from the fingerprint or in newborns from the heel. This makes this method less invasive and fully compliant with all guidelines which we have, and significantly reduce the risk of anemia. Moreover, it allows for the more frequent monitoring, even at home, when patient leaves the hospital, which reduces the burden for both the patients, for health facilities, and parents in a pediatric patient's case. This slide compares these two approaches. Conventional sampling requires larger blood volumes. Vein puncture carries the risk of exceeding recommended limits, and it's significant burden for patients. Microsampling, on the other hand, require very small volume. Is collected by finger pricking, which is much greater safety and possibly of repeated measurements. It's truly paradigm shift, moving from the milliliters to microliters. The first and the oldest approach to microsampling was DBS, dried blood spot, which is very well known from newborn screening. The drops of blood are placed on the special filter paper, and this method has long history. It was introduced in the 60s on the last century. And thanks to DBS, early detection of this metabolic disease was introduced, and that it was this newborn screening is working because of this. This method is very simple. It's not expensive and don't require special infrastructure. And the samples are stable at room temperature. and don't require all the cold chain, and can be sent by regular email, which reduce the costs. And of course, it has limitations. The most important being of the called hematocrit effects, which affect the results. There are changes in volumes, accuracy, and regulatory acceptance. Nevertheless, DBS is widely used, particularly in screening programs, and some of countries decided that it is the best option for their patients. The next generation microsampling has two options. And at the beginning, I would like to describe that one which is used in our hospital. It's called volumetric absorptive microsampling. And the devices which can be used for that, it's Mitra and Hemapen, which is underdeveloped. And these techniques allows the collection of fixed, a very small volume, blood volume every time. Special devices ensure excellent reproducibility with the coefficients variations below a few percent. After brief training, the patients can collect samples themselves at home, and this part will be widely explained by Jacek. The only require is to store them to dry and protect the samples from the light. So it's very convenient and safe methods. On the other hand, we have modification of dried blood spot, which is called quantitative. It also allows us to collect a limited amount of blood. But from our experience, these methods are more difficult to collect by patients, and the getting the enough big drop of blood was more problematic than in the previous equipment. On this slide, you can see four the most popular devices. On the left upper corner is VAMS, which was selected by our team. Below that we have Hemapen, but Hemapen it's now not produced. And on the right side there is quantitative blood, dry blood spots. Up on the up it's Hemaxis and Capitainer on the bottom. See, you can see the instruction from VAMS, Mitra VAMS. As you see, it's not very difficult. You can also see on this color picture show when the samples are collected in the right way, or when it still needs to be corrected. One is on the one the drop was too big, on the other there is not enough blood collected by devices. Our team prepared the methodology for all immunosuppressants used in pediatric population, and this part will be explained by Arek. And the very important part are the costs, because now we are used to immunochemistry methods, which are quite well developed and widely used. In 2016, there was the publication in PLOS ONE, described the cost of DBS versus conversion standard procedures, and this paper shows that microsampling it's not only about convenience and safety, but also about the measurable cost saving. This study compares these two options in hospital-based sampling versus making that at home. And the results show that the cost reduction was more than 60% from the social perspective, mainly by reduce caregiving productivity loss. So parents go to work, not go to hospital with children, and lower travel expenses. From the healthcare perspective, saving was around 20%. Training costs were quickly recovered after only a few samples sent to hospital. And additional advantage was the possibility of collecting samples at optional time, for example, at the trough level, right before the next dose of the drug. And I would like to summarize before we go to next part. Microsampling is the major opportunity in pediatric transplantation. We reduce the risk of edema, the patient discomfort, and it could give the reliefs for hospital systems. It allows more frequent and accurate TDM and lowering the costs. From my perspective, from the laboratory perspective, this too opens new possibility from the clinical trials to routine TDM or home-based care. And microsampling makes blood collection as simple as a child's play. So for our patients, it was very interesting options, but Jacek will send more about direction of the patients for this kind of collectings. So it's the end of my part, and at this point I would like to hand over to my colleague Arkadiusz, who will discuss the analytical aspects of microsampling.
I would like to show some of our applications in real clinical practice, because microsampling is a relatively new technique, demonstrating of equality between routine metrics, such as whole blood, normally used to determine the immunosuppressants, and capillary blood is crucial because the capillary blood composition is different than whole blood. The capillary blood contain sometimes more plasma fraction than whole blood. In case of tacrolimus, it was our first application. The equality was very, very good, measured using passing Bablock regression, and mean bias was around 2.7 minus 2.7% currently, because it's more than 300 samples currently was compared. In case of tacrolimus, the whole blood and capillary blood, the bias is lower due to more because of more samples have been included in the analysis. The next application is cyclosporin A. It's the same situation as in tacrolimus. This method is enable to determination of cyclosporin A in C0 point and C2, so it's trough concentration, and 2 hours after drug administration. The bias is relatively low. The third one was sirolimus. Sirolimus is the rare drug used in the pediatric transplantation, but we found a few patients, and we introduced the microsampling in case of patients under sirolimus treatment after renal transplantation, and the same situation was in kind of sirolimus than cyclosporin A, and tacrolimus. The bias was the bias was acceptable because IMTDMCT, it's International Association of Therapeutic Drug Monitoring and Clinical Toxicology, recommends that bias should be lower than 10 plus minus 10%, so it's acceptable. The issue is if our drug is distributed mainly in plasma. Mycophenolic acid normally is determined in plasma or serum. So the recalculation of concentration from capillary blood to expected plasma serum concentration is necessary. We perform that study, and we found that the plasma and VAMS levels are not equal. The correction is needed. We see the bias between plasma levels and VAMS was 54%. It's too much. So we performed the clinical validation in independent group of patients, and we introduced two formulas. The first one based on individual hematocrit level. It's necessary to measure the hemoglobin in the VAMS. It's possible, and the hematocrit is estimated based on hemoglobin level. And more suitable for daily clinical practice is the formula for recalculation. It's still used in our daily practice in the pharmacokinetic profiles of MPA, and we have another formula for glucuronide of MPA, and it still works good. But this formula is for renal transplant patients, pediatric renal transplant patients. If we want to use this formula in other kind of grafts patients, we should evaluate them additionally. In progress or after finishing is some of our other application. We try to collect the oral fluid. It's saliva using MITRA-VAMS. It's possible, and the equality between the classic salivate system and VAMS is acceptable. Creatinine is concomitantly measured with immunosuppressants in the same run, and currently we prepare the manuscript according to creatinine. In near future, we will start the determination of clinical samples of azathioprine. It's not measured directly. The azathioprine is measured using 6-thioguanine, and we finished the measuring of steroids. And I would like to show the new system. New system is Capitainer SEP10. It's new system to collect the plasma. The patient put the capillary blood to this inlet, and the system filtrate the blood and generate the dry plasma, and the circle with dry plasma should be blue if the sample is collected well. We finished the study with MPA and NPAC now, and it was a preliminary study. And now I would like to show how we perform the pharmacokinetic profiles. It's some examples. The first one is to concomitantly measure the tacrolimus with mycophenolic acid, and we perform the simple but full pharmacokinetic analysis, and Jacek interpret this data and adjust the dose, or we help with the dose adjustment. So it's the concomitantly measuring of the tacrolimus and mycophenolic acid in the same samples, so the patients collect the one sample time point. The second one example is when it's the same patient profiles, but collected in different time points in the February, April, and June. And we may monitor the adherence if we can. If we want to, we may calculate the concentration to dose ratio. And this technique. It's nice to measuring in home, collected in home by patients. It's ready to home-based self-sampling process, and these profiles were collected by patient in home, and the samples were sent to our laboratory. This profile is collected from patient in early stage after renal transplantation. We can see the high variability of concentrations in measuring in 1 month about, and after that, the doctors observed the variability, and we decided to collect the pharmacokinetic profile. And however, the concentrations were variable. The AUC was within acceptance criteria of from 0 to 12 hours. I would like to show one profile from liver transplant, pediatric liver transplant recipient. The VAMS technique can help us to identify the patients with the critical toxic concentrations. And this is an example of patient with extremely toxic concentration. It's about 55 nanograms per milliliter. Patient was under the concomitant treatment with fluconazole, but the profile was collected above 48 hours after the discontinue of fluconazole treatment. Sometimes ganciclovir or valganciclovir is integral part of immunosuppressive regimens, and we performed the study with comparison of two devices, quantitative dry blood spot and VAMS. We found that the ganciclovir levels in capillary blood, plasma, and whole blood are similar. Therefore, the correlation formula is not necessary to recalculate the levels. It's a very nice situation for us because it's no additional steps are needed to give the results to clinicians. We performed the preliminary study with ganciclovir profile, and however, the trough concentration was too low. The target is from 0.5 to 1, but total exposure fall within the recommended AUC. So the VAMS technique helped us to assess the total exposure for drug, and we should remember that for ganciclovir, the recommended pharmacokinetic parameter for routine TDM is AUC, not trough concentration. We performed a study with randomization. It was 2 groups. It was in stable renal transplant recipients under Dr. Rubik supervision. And we calculate the concentration to dose ratio, and we can see that some patients were stable, but some patients were characterized by high variability. And we found that in the VAMS group, it's the patient, the patients were collected, the samples from these patients were collected using VAMS in home. It's extra additional samples. And the second control group was only venipuncture collecting of samples. And we found that the variability of CD ratio in the VAMS group was lower. The mean of this parameter was lower than in control group. So it's nice to implement in clinical practice to identify of non-adherence. And I would like to show the correctness of sampling in in our patients. To date, 1,700 approximately samples were collected, and we found 6 empty VAMS. So patients were not collected the samples, and 45 of underfiled VAMS. So this tip should be red, and they're fully loaded with blood. In case of 45 samples, we found that the tip was not fully loaded. So these results cannot be implemented to clinical decision. I would like to show the work of our colleagues from Norway. They performed the study with supervision or not supervised collecting of samples. So it's necessary to training patients, training the staff. It's the nurse of medical doctor to appropriate collecting of samples, because it's crucial to give reliable results. And at the end, I would like to show one of new microsampling method to collecting of blood from the United States. It's similar to glycemic sensors, which are popular now, and it's enabled to collect the liquid blood, not dry blood. And I give the floor to Dr. Jacek Rubik now.
So I'm head of the transplant clinic at the Children's Memorial Health Institute, and this is probably the clinic that takes care of the largest group of children after kidney transplantation in Europe. So it's difficult to add anything to the information provided by Agnieszka and Arek regarding the VAMS technique we use. So I will summarize its advantages to the clinic, and we have huge number of patients. Since 1986, we transplanted more than 1,200 patients, and now we have more than 250 patients under care. So scheduled visits are every 3 months for stable patients, and very often we should perform additional visits in unstable patients and in patients just after kidney transplantation. So it means that we have more than 2,500 visits per year, and it's a big challenge for the patients and their families, and for the staff, because we have only one full-time doctor and one part-time doctor and 2 visiting doctors. So therefore, in case of minor medical problems, we sometimes seek help from the local nephrology centers closest to the patient's place of residence. And routine scheduled visit for the patients include medical history, physical examination, laboratory tests, and imaging studies, and also drug concentration monitoring. Especially important is tacrolimus. And for some patients, this measuring can be performed more often than every 2-3 months, and performing this test locally is usually more difficult and expensive. So we all know the mechanism of action of tacrolimus. It is very similar to cyclosporine, but tacrolimus is 100 times more potent than cyclosporine, and this is very strong, very effective drug, but treatment with tacrolimus is a major challenge for physician because of very high intra and interpatient variability in pharmacokinetics. A lot of factors can influence pharmacokinetics, and this is why the measurement of tacrolimus is obligatory, and especially in children, non-adherence is very often. So monitoring of tacrolimus is obligatory because of the narrow therapeutic window between toxicity and efficacy, very high intra and interpatient variability, non-adherence, and also we all know that adequate exposure to tacrolimus is critical for long-term treatment outcome. And we all know tacrolimus very well. I remember the first patients treated in 1996, and now more than 80% of children after kidney transplantation is treated with tacrolimus. So we decided to do something with our problems and to make life easier for our patients and ourselves. We ask ourselves the questions: is there a way to increase supervision of immunosuppressive therapy with TAC, which is simple, not burdensome for patients and staff, not expensive, and the method which can be performed remotely? So in this statement, this is second consensus report from 2019. Microsampling with VAMS were mentioned, and the first our step was to choose the sampling method, and we choose the VAMS technique. Then we validated this method. Agnieszka and Arek very elegantly showed this validation process. Then we checked what solutions are used in other pediatric centers. I can show you results of our survey. And then we performed several own trials, very small trials, to prove the possibility of self-drawing blood for single measurement and profiles. And then we implemented this method into routine practice for tacrolimus. We measure C0 concentration and area under curve. So we are going to routinely measure also other drugs, but now we focused on tacrolimus. And there was a small survey. I asked all centers which reported their data to a certain registry, and asked them how is their routine practice. And more than 50% of clinics perform tacrolimus measurements less than every 8 weeks, and only 3 centers can measure tacrolimus in blood taken by parents or children in home. So I think it can be new and interesting for others, our experience. So in my opinion, there are a lot of clinical advantages of VAMS method. The first is that the very small amount of blood is needed, and without having a puncture a vein. The technique is very, very simple, easy to teach patient, caregiver, and even older child. There was no situation that patients or parent couldn't be teach this technique. And also it's very important that the blood collection is possible at home and sent by mail without having to contact a health care facility. Also, this shipment is legal because Mitra is exempted from the regulation AN 3373. So you can post it with any problem. And also this sample is stable in classic condition. So the only disadvantage, the only clinical disadvantage is that we can wait a few days for the result. And there are some clinical situations in which the VAMS method proves to be particularly useful. In non-adherent patients, in this group patients, we can perform additional C0 measurements between scheduled visits, even every 1 week. And the patient know that we know that he or she doesn't take drug. It's also very important for patients living far from our institution as a supplement to the test performed in the local hospital. And also it can be very good in epidemic state, for example, COVID-19 epidemic, when contact with healthcare facilities is limited. And I think I will ask Arek to have a summary of our speeches.
Mm-hmm. So we prepare some take-home messages, regardless of adopted methodology. It's microsampling tools, the introduction of alternative sampling strategies, facilitates the daily practice of TDM. So it's that's as Jacek told, it's very practical to clinicians. The main advantage, apart from reducing the volume of collected material, is possibility of remote controlling and performing the TDM process. Microsampling improve adherence to therapeutic recommendations. Microsample techniques allow to the performance of tests which are difficult to perform in the daily clinical practice. Some of our dynamic PK profiles were prepared in the hospital. Some of them were performed in the home, so it's suitable to hospital and to home performance. These techniques allow to determination of practically all drugs and the most popular biochemical parameters. Together with Agnieszka, we are involved in the few other projects according to antibiotics, antivirals, antifungals, etc. in different populations in our hospital, and we found that this technique works. And I would like to show the total implementation of microsampling. The home-based remote self-microsampling will be collected by patients under supervision of caregivers and shipped to laboratory. We perform the analysis. Sometimes I perform the pharmacokinetic analysis if the doctor needs them, and gives the advice according to dose adjustment. So sometimes we use the remote tools such as application. We tested one of them, and at the final step, it's dosing recommendations for patients.